Hello, everyone. My name is Danish, and welcome to the 30-second monthly case webinar and also the final one of the series. We've had an amazing 32 webinars for the past 2 years. So, thank you to everyone that has joined and keep coming back each month as well. We'll shortly be joined by consultant radiologist Dr. Imran Lasker. Before that, I just want to introduce you to a new feature that we have on Collective Minds called seminars. This is an entirely new method for live teaching, which allows better interaction and a better flow of cases during the session. So this is the first version of this, and there will be more developments coming out in the coming months, including polls. So for the first time today, the monthly webinar will be done through a seminar. I'll be sending you a link and a password to this shortly, and then you'll be able to access Imran's cases as he presents them, and he'll be revealing the diagnosis of each case as he goes through the cases. Any issues getting onto the seminar, just give me a shout in the chat box, or you can email support@cmrad.com. And finally, there will be a CPD certificate available for everyone that completes the feedback at the end of the webinar. So with no further ado, I will pass you over to Dr. Imran Lasker. Thank you.
So hi everyone, thank you so much. I can't believe we've done so many of these. Yeah, 2 and a bit years of doing these monthly webinars. I'm very, very grateful for so many people turning up. I have certainly learned a lot from doing this, and also I think we've seen some serious improvements and crazy, crazy developments on the online platform that Collective Minds is. So it's been a real sort of pleasure doing this. So what we'll do what we usually do. I mean, some of you guys may be new, so I'll quickly tell you. So you will get a link to the cases that I have curated over the last few months. And then you will be able to also interact with me. I'll keep the web chat open, the Q&A open. We can all have a bit of a talk, go through things. It's meant to be interactive, nothing too serious. Hopefully you can tell by the way I'm dressed. I'm not wearing a suit or a tie. It's just me in the evenings going through scans and hopefully giving you a little bit of learning points from myself. I'm not saying I'm an expert. I don't always get it right. So I'm more than happy for someone to tell me, actually, hang on, that's not correct. And then, we all learn together. So let's start off with this X-ray. So this is the X-ray you can see on the screen. And at first, you kind of, for me anyway, I try and take in the X-ray. Like, is it young? Is it old? Like, what's the bigger picture here? And to me, it looks like an older person, mainly because they've got this sort of shoulder replacement sitting here, and they don't have much of a glenoid left. So this has probably been doing a fair bit of work over the years, and you can also see that the shoulder is kind of almost subluxed upwards because that's where the glenoid should be, and this whole humeral thing has gone all the way up like so. So that's one thing to sort of take note that this is not a young person. And then you can see that they've got breast implants bilaterally. You can see multiple calcifications located within this. So that's something that can happen over a period of time with breast implants. Now, I do remember when I was watching something where there was this lady who was very against breast implants and saying they were very dangerous and that kind of thing. And one of her reasoning for saying that was because she felt as though breast implants could obscure images when it came to looking for carcinomas, cancers, any lung abnormalities. And yeah, I mean, that is actually probably true because you can see over this area, this breast implant is causing a lot of shadowing over here, which would make looking behind this area here quite difficult, wouldn't it? I mean, you'd have to sort of try and see if there's a pattern difference and that kind of thing. But this particular breast implant has kind of moved out the way, right? So this is very, very far out the way when you're looking at this particular X-ray. So now when you're looking at this X-ray, I always have like a very specific way of doing things. I always, first of all, take a look at the lungs, almost do like a zigzag thing going all the way down like so. Just have a good look, just make sure I have a good, nice view of both sides, right? And then I always make a point of looking at the lung apices because that's where you can miss like really small pneumothoraces. So that's the next thing I do, just make sure. And what if you don't know, you have a look at these sort of linear lines going all the way across like that, and they should go all the way to the edges. Never ever get fooled by this scapula. Okay, this scapula here is the scapular blade, and you have to just follow that all the way around to make sure that you're not mistaking that for a pneumothorax. Now you've got this circular thing over here, and that's actually the aortic knuckle or aortic arch. And again, you can tell this person's slightly older because they've got this sort of atherosclerosis sitting along the outside. You can see a bit of atherosclerosis going all the way down there, which happens as people get older. I know there are other causes for that, but generally speaking, the older generation will have calcifications within the vessels more likely than someone younger. You can get calcifications from vasculitis, infections, all that kind of thing. But I think a combination of this, and this is telling you this person is a little bit older. So what they've said here is shortness of breath and a strong smoking history. So we really got to think about what could be going on. Right, so the next thing is to have a look at the cost-phrenic angle. So that looks very, very sharp. But this one, I don't think I can 100% sort of draw it along. And I really try and go with 100%. So can I be 100% sure that there is no cost-phrenic angle there or isn't there? And to me, I can't be 100% sure that there is a cost-phrenic angle. So I'm going to have to say that that is probably abnormal. Now, the next thing I want to do is try and see whether there's any tenting of the hemidiaphragm. There doesn't seem to be that way, but it just feels like this is going all the way up like this and maybe up like this. So then we're looking at a meniscus. The next thing to do is to look at the hilar regions, and you can just about see that there is sort of a bronchus there, and you can kind of see of almost V shape. And this takes a long time to get used to, but I think at this point in time we can say that we feel that there's some sort of underlying lesion located within the region of the mediastinum or the hilar regions either. But then you've got the breast implant there, you've got your breast implant there, but there is something that is located along this area over here, and this doesn't look quite normal. So just to show you some of the capabilities, you just like any other pack system, you can zoom, you can pan across like this, really bring it into center and really have a good look at that and think, okay, what is going on? And actually recently I've been finding it quite useful to just actually measure how big something is. So let's get that line again. So measure. And yeah, so we can draw it along like this, and that looks like what? It's about 5 centimeters, 5 centimeters, quite spherical lesion located within the left lower lung zone. For those that don't know, what you need to do is just split everything into lung zones. That's going to be upper, middle, and lower lung zone. So let's just keep it simple. This is within the left lower lung zone that does look like there's some kind of lesion that is sitting there. So what do? We measure it. We say, look, there's some kind of lesion, and there's an associated what looks like a pleural effusion. There's fluid located within this left hemithorax as well. Being an older patient with a long smoking history, we do need to get a CT scan, and that's exactly what we've done. So you can actually click on download just to make things easier when you're scrolling through the images, but I've tried to keep the images fairly small so we're not having to download too much. And don't worry, even if you do download the images, it doesn't stay forever. It will delete when the next time you come in and out of the Chrome browser. So I always do one scroll through, all the way down, all the way down, and all the way back up again, just to see if there's anything grossly abnormal. To me, something grossly abnormal has come around. So again, this is such a good sort of pack here. You can actually, I think it's number three, four. Number four gives you the long windows, just like you'd expect at work. Scroll, 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 scroll. And then as you keep scrolling down, you can see that there is something very, very abnormal about this area over here. And it does feel like it corresponds to whatever we were seeing earlier. So that corresponds with that. It really does. So now we can see that there is what looks like a spiculated, quite large lesion located within the left lower lobe. It goes all the way down and almost touches the lung base, and it feels like it might be associated with the pleura. There's definitely some sort of pleural effusion there, but that feels like there can be a bit of pleura that's stuck there. So you've got to be a little bit concerned. Chest wall wise, it doesn't look like the intercostal muscles are involved. And you can see the bones actually look okay, but we do need the bone windows to have a look. And again, I think you can press number 3 to have a look at the bone windows, and the bone windows actually look like they're not involved at all. So, okay, so we've got a lesion that is located here. It's closely associated with the pleura. It does look kind of abnormal, doesn't it? It doesn't look like a uniform lesion, because if you draw around, it looks very, very spiculated. And within it even, it's got the sort of fluidy areas that's located within it. So this looks like some sort of necrotic large mass located within the left lower lobe, which is also causing a little bit of a tethering of the underlying skin. As well, underlying pleura. So this kind of starts to make you wonder whether this could be, what stage of carcinoma this could be. We do have to look around to see if there's any sort of satellite lesions, any other lesions anywhere else. And it does look a little bit mucky and messy within the lungs, but I think that's probably because of the underlying smoking history. Scroll through, scroll through, scroll through. You do have to look at the upper abdominal solid organs when you can. Just have a look at these adrenal glands if you can. Sometimes they're not included. I think the right side is not included. The left side, you can just about see a lymph node there. So we can't see any obvious metastasis, but ideally you do want to go on to get further imaging to try and see whether this person's got any distant metastasis. Now, I always used to get spooked by some of this sort of abnormal looking liver. So that if you see that liver there, it looks slightly different there. But when you're not doing dedicated images for the liver, then it's just probably going to be perfusion abnormalities. And then you do need to get a CT abdomen and pelvis just to have the proper imaging for this particular patient. So over here, this is really good for teaching. You just click on this one, and I've written that's a T2 in my opinion because it's about 5 centimeters, and associated flora N0 MX. So N0 means no lymph nodes, from what I remember. I couldn't see any lymph nodes on this one, and I couldn't see any distant metastasis at this present time, but I wouldn't call it just based on the images that we have. Right. So what we can do now is go on to the next case that we've got, and now we're kind of a bit more used to the cases. We could the way this whole system works, it kind of just goes between each of the images that we put in for this webinar. You can see how useful this would be for if any of you guys would decide to do teaching through your hospitals or your universities and that kind of thing. What we have here is shortness of breath and weight loss. Okay, so first off, let's do my usual thing. Look at the lung apices, make sure they're clear. Lung apices look clear. Prostaphenec angles compared to the last one look very clear. Kind of go along like this, go along like this, go along like this, and this all looks like it's clear, but there is obviously something that I can see that I'm not entirely happy about. So you got your, oops, sorry, we got your cardiophrenic, you got your cardiac border over here. And over here you can see your descending aorta, and it feels like it goes this way, but then there's weird lesion that's kind of sitting outwards from everything. So you got to try and think, okay, so it's well circumscribed. It doesn't look spiculated like that last patient. The last patient had a very sort of spiculated appearance to that lesion. This one looks very, very spherical, doesn't it? It looks very spherical. And then what else can we say about it? So that looks like the bronchus, and that looks like the hilum. So it doesn't look like it's really coming from the hilar region. Looking at the posterior ribs, it doesn't look like it's pushing the ribs outwards. So we can't say it's some sort of neurogenic tumor, because if it was a neurogenic tumor, it could be pushing these things and causing splaying, what we call splaying of the ribs, kind of pushing them outwards like this. But actually, when you look at the ribs, they all look okay. It doesn't look like there's any erosive appearance at all. So what we do have is a very spherical lesion that looks kind of uniform in its appearance, emerging from what looks like could be the mediastinum. So what we need to do, I would say, is just to zoom a little bit more, just have a closer look. And now when you look, you can see this sort of hyper dense stuff sitting just around the peripheries of this, and maybe some there, and maybe some there. And I always try and say, go back to basics. What is hyperdense? What is low dense? What is kind of in between on an X-ray? If you're not sure, just use the tissues that you know that are there to try and guide you. So this is what soft tissue looks like. It kind of looks like it could be soft tissue, so that's good. It doesn't look like air because that's what air looks like. And then you've got these bits which are bone, and it does look like it could be slightly bony. It looks kind of dense enough to be bits of bone that are sitting there. So you've got a predominantly soft tissue density with some hyperdensities located within it. So at this present time, without knowing much more, this could be something like a hamartoma. Hamartomas have got these dense calcifications located within them, very well circumscribed. No real symptoms. It's kind of normal for this patient to have. But we're going to have to do a CT scan, as you can imagine, because we need to know what's actually going on here. So let's open the CT scan, which is over here. And what I'll do is I'll put this X-ray next to it. And then what we'll do is scroll through at the same time. So we scroll through. It looks like we did a contrast enhanced study. Scroll, 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 all the way down, all the way down to the very, very bottom. Okay, so what have we thought so far? This doesn't look normal. Okay, that's for sure. And now we can actually see some of the calcifications that we were talking about earlier that correspond to some of the calcifications that are located here. This is a contrast enhanced study because we can see that there is this contrast sitting here, which gives us a define, which enables us to actually define the aorta quite well. Coming up to the aorta, we can see that the aorta is over here, but there looks like there's a bit of a breach of the aorta, probably around that sort of descending aorta area. And then coming further down, this almost seems like a globular lesion coming off the aortic arch. And as you come further down, the aorta kind of resumes this normal caliber all the way down to the upper abdomen. So what we have here is a well circumscribed structure, and it doesn't look like it's got, so it does have hyperdensities within it, but it doesn't look like it's got any fat within it. So if it was a hamartoma, we'd be looking for fat. So let's see, if you do this measurement here, you can see that the Hauser unit is actually quite high, which wouldn't be fat, because fat, if you're ever unsure, you go to the subcutaneous tissues and you try and resize it to the size of the subcutaneous tissues like so. And you see that's going to be negative value, but that's a really positive value. Okay, so that's a really positive value over there, right? So compare it to the bone. Bone looks like it's about what, 250 or 300. Coming up to here, it's not quite as dense as bone, but it is quite dense. So therefore, this is probably contrast that is sitting within this region over here, right? And so therefore, This being contrast and showing communication with the aortic arch suggests that this is a really big aneurysm that this patient has had for quite a while. And thankfully, we have caught it and we probably have to do something. So this needs to be transferred or referred to the vascular surgeons. And actually, the interventional radiologist may be quite interested in something like this. Maybe they want to do some clever stenting or whatever they're into these days. We can see how actually maybe I'll be able to show you this thing. So you can do the MPR and go coronal, and again you can see like exactly how it is in comparison. You can really compare the two. And what I used to do and still do actually is if I have a CT scan and I've seen something interesting, I will have a look at the X-ray because over time that helps you learn. Okay, I've seen that before, or I can try and learn like why does it look like this on an X-ray? And this is what it ends up being on the CT scan. It's not a hard, fast rule. Sometimes the rules don't work, but I think we could tell quite a lot from this. And I think the differentials are quite decent in that we did come out with this potentially being a non-aggressive lesion, such as a hematoma or potentially something coming off the mediastinum, not affecting the hilum, not affecting the ribs. And that's exactly what this has ended up being. So yeah, quite interesting case of a aneurysm with the pre-CT and then also the corresponding CT scan. Actually, sorry, I forgot to show the diagnosis. So yeah, so the red herring was weight loss, but it's a large aortic aneurysm emerging from the arch. Okay, so let's have a look at this case, and can't see any questions coming up so far, so that's always good. So this is a CT scan that came in on call, head injury 3 days ago, okay, and they were on blood thinners, right? Okay, so let's have a look through. So you always scroll through, and I always do one scroll through from the very beginning. It just gives me an idea about what's going on with the scan, how old the patient is. It kind of gives me an idea about what I should be expecting in a normal scan. So with this one, we can see that there is some low density stuff just sitting around the ventricle areas. And so that's going to be small vessel disease. And that's very, very common as we get older. But it does look like there's a fair bit. So we could say it's sort of moderate small vessel disease. Also, you can see these big crevices sitting over here. If they were a very young patient where they've got a lot of fluid in their brain, you wouldn't see that. But this one's got maybe a potential, yeah, about a small amount of sort of mild involutional changes all over the place, scrolling through, scrolling through, scrolling through, scrolling through. Good. One of the other things I try and do is try and see if I can see any subcutaneous hematomas. Subcutaneous hematoma means that you've got your cutaneous skin, subcutaneous fat, and there's always a good thing just to have a scroll through just to see if you can see any bruises or anything like that. But here, I don't think we can see any bruises at all. So we'll go back to the bone windows, the brain windows, and have a closer look and see what's going on. So when you scroll from the very top, this is what the CSF fluid looks like. This is what the CSF fluid looks like, and it all looks okay. But actually, it starts to look a bit asymmetrical. And one of the courses that we run, we always say, um, parade order seminars, we will say the CSF spaces are probably one of the most important things when you're looking at the intracranial, looking at the brain, because it gives you an idea about whether there's something there that shouldn't be there. And you're also looking for symmetry. So this one looks asymmetrical to this area over here. So there's something that's going on over here that doesn't look quite right. And as you scroll through, you feel as, okay, that looks like CSF, that looks like CSF, but this looks a bit dirty. It looks like there's a bit graininess to it. As you come further down, it looks slightly more hyperdense, almost close to the brain parenchymal density as you go further and further down. So this looks like a chronic subdural hemorrhage. And you can see actually here, there's going to be a few different ages. This is very old hemorrhage. You got your sort of slightly hyper dense stuff that's sitting over here. So that's sort of slightly newer bleed. But then you've also got this stuff that's almost the same density as the brain. And this can be really confusing when you're doing on call, because if you go through the scans too quickly, you may have a bleed that looks exactly the same density as the brain. And the best way to try and identify is by using that CSF rule. The CSF rule is very, very good at trying to help you identify abnormalities like this. And again, what we can do is get the measurements out, see how big it is, and also tell the clinicians the things that they need to know. So we can say that this is 1 centimeter maximal diameter, left chronic subdural hematoma. It is causing some mass effect. But when you look at the midline, this is how you draw the midline. Go from all the way down like this, all the way down like this. And actually, everything looks like it's nicely in line. Doesn't look like it's being pushed across. So we can say there's no mass effect at the time of the study. Now, it can get complicated because the bigger the bleed, the more secondary complications that can occur. You can get ischemia because of the mass effect onto the vessels, but this one looks like there's no ischemia or lack of blood flow. The blood vessels actually look okay. This looks like a solitary subdural hematoma. Oh, and one more thing I want to say is that Sometimes you get confused. Is it just atrophy or is this definitely a abnormality, right? Especially when it gets to sort of fluid density, it can be tough. But you got these cortical veins. Can you see that? So cortical veins, if this is normal CSF fluid, would go right in the middle here. But because it looks like this cortical vein, there's a little tiny dot. I'll zoom in just to show you guys. So zoom in. This tiny dot is a cortical vein right there. And you can see that it's not sitting within that CSF fluid. It's kind of being pushed inward. So there is some mass effect onto the cortical veins. Again, telling you that this must be an abnormality, right? This is not normal for this person. This person's had a subdural hemorrhage. So let's have a look at what they've said. Left-sided chronic subdural hemorrhage, right? So good. So this is what's, well, not good for the patient, but you know what I mean. It's quite an interesting case with a few learning points there. Okay, let's have a look at this one. Um, so abdomens are slightly more involved, I think, in my opinion. You've got to really look at quite a lot. With the brain, I know neuroradiology is going to say, what are you talking about? You know, it's all hard. Neuro is like the hardest thing on the planet. But I personally find that the abdomen and pelvis is really, there's just a lot that can go wrong and a lot that's going on. And sometimes the symptoms don't really match up at all with what you're seeing on the screen. So let's have a look at this one. They said sudden onset abdominal pain. So they look like they could be quite young, this person. They've got a fair amount of good muscle mass here. The bones don't look like they're particularly old. They look very, very smooth as you go along. Maybe I'm just being an MSK radiologist at this point. And let's scroll all the way down and all the way down, all the way down, all the way down, and all the way down. So, okay, at first, we're not really seeing anything wrong. Let's see if anyone's saying anything. No. Feel free to give your diagnosis and tell me what you think. But at the moment, I haven't seen anything grossly abnormal. So then I always follow a system whenever it comes to CT abdomen and pelvises. I always kind of look at the liver first. So look at the liver, make sure it's all okay. It looks okay. Looks like the portal vein is patent. Gallbladder actually looks pretty good. Looks like the gallbladder is so it's fine. But there is this weird thing that's sitting here. So I'm gonna have to come back to that. I'm not entirely sure what that could be at this stage because it almost looks like they've got two gallbladders. And as far as I'm aware, that's not really something that you see very often. Okay, so we've got your adrenal glands that are sitting over here. What else can cause this person pain? The kidneys can cause pain. These are the kidneys that are sitting over here. Scroll down. No, kidney looks okay on that side, and kidney looks okay on that side. Now we look for the pancreas, and you've got this leafy thing that's sitting along like this. Looks very smooth. Doesn't look like there's much going on. So it looks like a very nice looking pancreas. Fat stranding wise, that's the fat that's sitting over here. Doesn't look very like hazy. Looks relatively okay actually. So I'm not particularly worried about that either. So I haven't found anything grossly abnormal, but this person has come in with abdominal pain. So we may have to go the long way around and go from the rectum all the way up to the sigmoid colon, which is over here. We scroll along like so, scroll along like so, all the way up here, go across to here, then come all the way up. So I always say the constants in life or in a human body is going to be the ascending and descending colon. Sigmoid colon, transverse colon, they can wave around. These two areas will normally be around around the sides, right? So then if you ever lost, come back to here and then follow it down again. Just follow it down and see where it leads you. And it feels like it goes that way, that way, that way. But anyway, we are now coming up to the splenic flexure and it looks okay. We're coming across again to the top. Oh, hard to see this transverse colon. Where are we? Is it that? It must be that. No, it's a hard one, this one. Going across. Sometimes it goes down and up. Have I gone back on myself? It's tough. Okay, let's just go back to another constant. So this should be the hepatic flexure, should be a constant. Very, very difficult. I think they are somewhere here and maybe coming across somewhere. It's quite hard to see, but I don't think we can see anything grossly abnormal with the bowels here. Okay, so that's fine. So what we'll need to do is try and have a look at the lung window. So lung window is number 4. And the lung bases, let's see what they look like. They look pretty clear, don't they? The lungs look clear. Oh, but hang on. There is something up here because that's the diaphragm. Oh, someone's got it. Good. So that's the diaphragm coming up, coming up, coming up. And it ends here, doesn't it? Diaphragm ends. So all air should end. But there's that bit there. Can you see that? That looks like it comes out of nowhere. So come back up. Yeah, it's definitely after the diaphragm. So under the diaphragm, there is some free air. So, okay, we have to think about what could be causing that. Let's scroll around and see if we can see any more free air than anywhere else. And actually now you feel like that there could be some free air there and some free air there. Okay, maybe a few dots here, maybe a few dots here. So the things for me, I'll be thinking, okay, we've got free air. It could be appendicitis, it could be diverticulitis, or it could be a duodenal ulcer. So we've already had a look at the large bowel, and we haven't seen anything grossly abnormal. We're going to have to go for the duodenal ulcer and see whether that could be the issue. So that's the stomach coming across like so, and it does feel that there could be. Hang on, let's try and see if I can find something going on there. Right, let's do that again. So let's go to lung windows. There's a bit of air that's just located with the falciform ligament area. No, falciform ligament's over there, yeah, but you can see that there is what looks like air tracking across like this, across from there. So that doesn't seem right. And then that might be why there could be a collection located over here. So what we might need to do is go on the coronal views. Oh, I don't have the thick, I've got slightly thicker slices. So it might not be the easiest way to see, but that thing there looks very separate. I haven't been able to really 100% draw a line going there, but this does not seem right. There seems to be air going from the duodenum kind of upwards and upwards to this way. So even if I didn't see that, in my humble opinion, what you need to do is say that I can't. Let's say you can see where I feel the perforation is. You'd have to say the predominance of air in the upper abdomen would suggest that this may be in keeping with a perforated duodenal ulcer. That's all you can really say if you can't see the perforation, because you can't always see the perforation. But the other thing that makes you wonder there could be a perforation is that kind of weird looking collection sitting in the upper abdomen and the free air that's really kind of in the upper abdomen as well, that kind of all focally towards there makes you think that this must be a perforated duodenal ulcer. Good. So let's have a look. And yeah, perforated duodenal ulcer is what we've said this is. Good. So it could be. I mean, it very well it may be. So someone said, could it be a? I can't even say that word. So I'm going to just go at it, and please don't ruin me. But a figurine cap. Um, it may be, right? And that's why I'm saying that, like, I don't think we've got the best images for it because at the end of the day, these are slightly thick slices, but it looks so separate and it does look like there's a linear line. And the other thing that makes me concerned is that it does look slightly different density. Ideally, you would do an ultrasound, but in my practice, I would suggest that this is a potential because they've got a perforated duodenal ulcer, and I can't 100% say that I can see a connection between the two. It would just be something that I would do in my practice. You don't see the seek. I don't see the seeker in the right upper quadrant or the low quadrant. Yeah, I was finding it. Yeah, so sometimes you right low quadrant. Yeah. So sometimes this may be something that the patient's got where I've seen, I can't remember what it's called. I'll have to look it up. But sometimes you actually get like all the small bowel on like the right abdomen and some of the large bowel on the left abdomen. So the cecal pole may be sitting like right down in the middle sometimes. And this is why I don't do gastro because it drives me insane how mobile the bowel is, and that's why I do like MSK because if the knee moves, then you're probably looking at trauma scan and not an MSK scan. But yeah, I suspect yeah, I can see the cecum 100% in the right lower quadrant. Not at all. It's all small bowel, and I suspect that you're probably looking up somewhere here, maybe, or somewhere up here. Very, very hard, very, very hard. But thankfully, we don't need to on this particular scan. I think we managed to find the answer. Okay, good. So let's have a look at this scan and see what we think. So this person again, they've got a history of Crohn's and they've come in with right upper abdominal pain, right? So let's have a look and see what's going on. So go from the very, very top all the way down. I'm going to do one scroll through. I always recommend doing one scroll through because I always say this for the people who I do FRCR2B teaching for, right? Which is pretty rare these days, but I still do it on the occasion. But I always say do a scroll through because what sometimes happens is that someone will say they'll see this and they'll say, oh, okay, this is a CT scan of an abdomen pelvis. I can see that there is this low density lesion located over here. It's very spherical. It doesn't look particularly concerning. I'll do an ultrasound, I'll do an MRI scan, I'll do this and do this and say, okay, cool. And then they haven't actually gone down to over here where there's like a massive collection, perforation, all that kind of stuff. So it's better you just take one good look all the way through, take the scan in, try and understand, kind of get a larger picture whether this is serious or not serious. And if anything grossly abnormal pops at you, then great. And if not, then you're going to have to do a bit of hard work. So to me anyway, I haven't seen anything like grossly abnormal. So I'm gonna do one scroll down. I've been going up and down. So let's go one. Let's do one all the way down. Here we go. Here we go. If anyone sees anything, do let me know. Okay, good. So, yeah, I think we haven't seen anything grossly abnormal yet. So let's have a look at the pancreas. The pancreas looks very feathery. Yeah, so you can see there's a bit of featheriness to this where my mouse is right now. So the pancreas looks good. Let's look at the adrenals. Adrenals there, adrenals there. They look good. Let's look at this kidney over here. Yeah, that looks fine. Doesn't look like there's much going on. Looks like a cyst there. Look at that kidney over there. That looks good as well. Okay, okay, fine, fine. Let's have a look at the bowel. So yeah, look here, you got two inguinal hernias, I think. A bit of fat sitting there, but that's fine. Let's follow the bowel, follow the bowel, follow the bowel, follow the bowel. And you have a few diverticular, but it doesn't look like they've got any inflammation there. So there's no diverticulitis. Scroll, 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 scroll. Now we're at the splenic flexure. Then you go across to the transverse colon, coming up to here. I think we're okay. And then we come all the way down, and then it looks like everything is all right. That was that terminalium going that way. Have we got an appendix? I can't see the appendix 100%. Maybe it's that thing there. Okay, okay, so that's the cecal pole because I mean that's the ileocecal valve. You can see some fat there. So that must be the ileocecal valve. So anything else in that vicinity might be the appendix, but I don't think I can 100% say I can see one. Okay, so they said right upper quadrant pain. So let's go up to the upper abdomen. We did have this low density stuff there, but actually there is some air located there, isn't it? Is that air? So let's go to number 4. And yeah, it does look like it's the same density of air as air, doesn't it? So come up, come up, come up. And there does look like it's sort of adjacent to the vein, but not in the vein. So that's kind of good news. We're not looking at um, air within the portal vein, which makes you think that this person's got underlying ischemic bowel or anything. But you can see the air kind of goes down that way. Oh, there's some air located within this thing over here. You come further down, and then it sort of disappears over there. Okay, so that is a CBD. So you've got a CBD that looks slightly thick wall to me, and there's some air located within there, but they don't, I mean, maybe they had some previous surgery or something like that. But now when you look over here, you can see actually there is some air located within the gallbladder there. But where did the air come from? And now you may be able to see that there is this sort of kind of pointing thing going this way, this way. And if I zoom in a bit, seems to connect with the bowel over here. Look, it looks like a fistula going all the way across like this. So this person's known history of Crohn's disease, and so when you get inflammation within the any part of the bowel, it can result in sort of sticking a bowel together, and over a period of time, things can erode through. Sometimes you can have it the other way around, where you have a gallbladder, a gallstone that's kind of eroded through all the way down, and then you might be able to find a gallbladder later on. This person may, I mean, who knows? Maybe they've got a few gallstones lying around. But actually, what you can 100% say is that they've got what looks like a fistula going between the gallbladder to the proximal sort of duodenum, and this must be communicating because there's air located within the gallbladder, which is not normally the case. And the CBD looks slightly enlarged to me, but I can't see any calculi located within there. So maybe there could be an element of inflammation or something like that. So let's have a look and see. Yeah, I'm not even going to try and say that word like you tried to make me say the other word. Um, Fistula and hyperenhanced CBD suggests inflammation. It could be. So yeah, that's quite an interesting case. And I think that at first you may not see that, but once you see the air and try and figure out where the air is it vessel or is it biliary tract? And once you figure out it's in the biliary tract, you've got to start thinking about where this air came from. And of course, you can have sphincterotomies and that kind of thing. But in this particular instance, it wasn't a sphincterotomy, it was actually a fistula. Good. So let's go to the next case. Oh, yes, I remember this one. So this was a young girl, 29 years old, coming in with severe back pain, saying point tenderness on the spine. And they were really concerned that this person, and they had white cell count that was raised, and yeah, white cell count raised, rigors, fevers, and palpation tenderness in the spine. They were like, look, this person's got some kind of discitis, and it was out of hours, so they couldn't get an MRI scan, so they decided to put her in the CT scanner. So we did the CT scan and we can see it's a contrast enhanced study. And because we're going to be looking for discitis, I am going to use the very capable sagittal views. And you look at the discs, and it can be a bit difficult for those that do MSK. Obviously, CT is not the best way to look at the discs, but in an emergency situation, for whatever reason, this was done. But you can see just about like a bit of a disc there, a bit of a disc there, and a bit of a disc there. And you can see that this kind of material is holding it all in place. And this is your intervertebral disc, right? It's very gelatinous. On the outside, it's going to be very, very fibrous. And then inside is going to be kind of like a burger. I always say it's like, look, like a bread and a burger and a bread. And then sometimes you get a bit of a puncture and you get a bit of squeezing out toothpaste that can cause all sorts of issues. But we're here because we're thinking this person may have something to do with some sort of underlying infection that's causing destruction of the bones. So now what we have to do is have a look at these vertebrae, and you get a little bit of a dip anyway. If there's too much of a dip, then you have to start thinking about other things like sickle cell, osteoporotic collapses, and all that kind of stuff. But this one, this is kind of the shape that you'd expect, and it actually looks okay. This looks very good. This looks very good. I always say this to people, don't get concerned about this little thing here. For those that don't know, I have definitely mentioned this before. This is a basivertebral vein. I did actually remember it very clearly because I do remember it very clearly because I did mistake it for a fracture many years ago as a registrar and was told quite stiffly that it wasn't. But this is very well corticated and you'll see them in the middle of every single vertebra. So nothing to worry about. This is normal and a lot of people have it. Sometimes they're not as obvious, but this one looks like they're pretty obvious. So we're not looking at any kind of fracture. Interestingly, they do seem to have this line going up there. Not entirely sure what that is. We can try and take a look. But this is the pedicle of one side of the vertebra. You come up to this side, you've got your vertebra, you've got your facet joints, they all look okay. And this very looks very well corticated. So I can't say I think that they've got any sort of abnormalities um, when it comes to them having discitis. The vertebra look good. There's nothing going on there. So we could just say, okay, fine, there's no discitis, let's move on. But the person does have fevers. They do have a raised white cell count. So I'm gonna just put it here and just see if anyone can tell me if they think they can see anything. So the way I would do this, yeah, exactly. Well done. So when you look at the kidney over here and look at the kidney over here, it does look slightly edematous. It does because you've got a nice little fat bit here, but the fat bit is not as obvious in some areas. But more importantly, around the kidney, you've got this fat. But this fat is black. This fat is black, very, very dark, very, very dark. And then around here, it looks very, very strandy. Very, very strandy, right? So then, therefore, that must mean they've got perinephric fat stranding. Now, if you look at this ureter over here that's coming out, very thin, doesn't look like there's any fat stranding there. Look at this ureter over here. You can see it looks slightly widened. And actually, the ureteric wall looks slightly bigger and fatter, maybe slightly hyperenhancing. You can still see it there. So now you've got to be concerned like there. Can you see how kind of thick walled that is? And sometimes that's all you see. So they've got significant fat stranding. When you come to this level, you can see quite a lot of fat stranding located within the right kidney. Therefore, yes, exactly right. Someone says this is pyelonephritis. At this point, I can't tell you whether it's because of a calculus or anything like that. But this is what pyelonephritis would look like, and it's probably the most likely or more likely cause of the patient's pain and fevers and all the rest of it. So yeah, misdiagnosis, don't know, maybe. But fair enough. Like when you're on call, you've got a patient who's writhing around, you got to be concerned, you got to be worried, you got to take things seriously. Okay, so let's download this one and download this one. Again, so now we've got another CT, no, we've got an X-ray of the abdomen. And at first, I think these days you kind of just say, oh, okay, yeah, normal, no gross abnormalities, no airfield bowel obstruction, everything looks fine, let's move on. Person's come in with right lower abdominal pain, bowel's not opening. And when you look at that right lower abdomen, it does feel like there could be something going on here. So this is going not all the way across, it kind of stops. So this must be Haustra. If this is Haustra, this can be large bowel, not small bowel, because small bowel will be more centrally placed. I want to have lines going all the way across. This one feels like it goes halfway, maybe slightly more than halfway, and doesn't go the rest of the way. So we're concerned. We are concerned that there could be something going on in this region. It feels like they're slightly dilated, but you've got a person with abdominal pain. Let's have a look and see what's going on. So let's go from the very top. I'm going to do one scroll through all the way down, all the way down. Keep going, 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 like so, all the way down to the very end. Okay, good. So what we'll do now is bring that there. So what we saw was around this side that there was something up. And it feels like that corresponds with that, doesn't it? It does look like these are similar entities to one another. Okay, so we are looking at the area of concern. Okay, so then what we need to do is try and figure out what on earth is going on with this bowel. And as you kind of come up, you can see there's all this stuff around it, lots of fluid just sitting around the bowel, sitting within the abdomen. There's something not quite right about this particular area. Yeah, and it doesn't look like it's perforated. So let's go to the lung windows. And it doesn't look like it's ischemic because the bowel wall enhances quite nicely, maybe enhances slightly too much. And but it doesn't look like there's anything else going on. So what we need to do is sort of work from the bottom, I think. So go from here, scroll all the way up. So now we're here, sigmoid colon, descending colon, descending colon, descending colon, descending colon, going all the way across. Feels like it connects that way, maybe that way. Oh, and there. Can you see that? This thing here. And this is what it almost feels like an apple core lesion. So they say an apple core lesion is where you put contrast in, and when the contrast kind of goes through, you have a kind of drawing that looks like this. That's what the contrast look like, and it feels like someone's taken a bite out of the apple, and it feels like there's a very stenotic focus located around here, and almost circumferential bowel wall thickening here, which is resulting in some sort of hold up here, right? And actually, you can see maybe the small bowel slightly dilated as well as a result of as a result of this very stenotic area. So when you have something like this, upper core lesion, it has to be an underlying malignancy, and therefore they'll need to be referred for potential surgery. Just so that we have gone through some of the rest of the case. These are gallstones. They're not always hyperdense. Sometimes you can't even see them at all because they're very fat density. But you can see a few gallstones sitting there, which is interesting. And then also over here, you may think to yourself that this is hydronephrosis because it looks like there's these sort of multiple low density areas here. But actually, when you look around, hydronephrosis would get rid of any fat. But this one looks like parapelvic cysts. So these are parapelvic cysts, most likely bilaterally. I've sometimes seen that someone's worried and they get CT IVU. Fair enough. And what is someone saying? They said pathological nodes. Let's have a look. Let's see if I can find some. So a bit of fluid, small hiatal hernia. And let's see, you said you could see some nodes there, that one there, and another one there. So these are lymph nodes. So for those that don't know, everything in the human body kind of continues into something else. So this would go into the vessel, this would go into something else, but lymph nodes just sort of hung around. And that node there, they are in the vicinity of the abnormality and they're slightly enlarged and yeah, they're very abnormal. So they've got a few pathological lymph nodes. Yeah, this is concerning. And what I probably should do is just have a look at the lung bases. And the lung bases actually look okay, but there's a bit of a hiatal hernia going on here. Band of atelectasis, but I can't say I've seen anything else that's grossly abnormal beyond this. So they're going to need to be referred to the colorectal surgeons. Has anyone seen any osseous metastases? No, not at this stage. Good. So let's see what the diagnosis is. It's no secondary to colon cancer. There you go. Fine. By the way, if you do use it for teaching and you want to have this sort of reveal area, you can write loads more. I just did it like just to see if it works, but you can literally write paragraphs. So if you do want to actually end up using this, you can. And I think it's quite good because I can imagine if when I was a reg, this would be great to be able to work through the case, see the diagnosis, see an explanation and stuff like that. So yeah, this is really good. All right, let's have a look at this one. What do we think is going on here? So we are looking at an X-ray of the right radius and the right ulna. We can see a few wrist bones and we can see the humerus. So pretty much this is the forearm. And they said that this was hand pain, but they've done the radius and the ulna. So the radius is always slightly larger at the more distal aspect. Ulna slightly smaller, but then the opposite is true on the other side. The ulna is very large and the radius is very small. I generally, as a rule, I always try and zoom in and have a look at the radial head because sometimes there'll be like a fracture there or there'll be like a posterior fat pad that will tell you there's a supracondylar fracture. This one, I don't think you can say that. I think everything looks okay from that point of view. Let's scroll along. Distal radius doesn't look like there's a fracture. Ulnar styloid can get fractured. Doesn't look like there's a fracture there either. Carpal bones look okay. You can't really fully assess the scaphoid, which would be sitting over here. But as far as I can see, it doesn't look like it's too bad. But this area over here looks very weird to me, right? So this is what normal bone looks like. This goes normal, 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 and then suddenly it starts to look really, really fuzzy, really, really hazy, really, really hazy, really, really hazy, and then kind of become normal and normal, normal again. So then you have to start thinking to yourself, okay, is this aggressive lesion or a non-aggressive lesion? And how am I going to figure that out? And this is pretty much all you have to do at this stage anyway, to know whether it's aggressive or non-aggressive. So first off, you've got to think to yourself, can I draw around this with a pen? And I can't really 100% draw. Like I think I could draw there, but I can't be 100% that that's definitely the edge. So you're going to say it's ill-defined. It's ill-defined, right? Cortex, what does it look like? Let's zoom in. So cortex looks relatively well maintained, but this side, it doesn't look good. It looks like the cortex is not well maintained, right? And actually, when you look at it, it looks very, very hazy, and you almost feel like it's kind of this linear sort of appearances over here, and almost a bit of more cortication just sitting on top. So if you zoom in, it's almost a linear cortication. So you're something's happening where it's causing destruction and the body's trying to fix it by laminating, adding more bone to the areas, but is not keeping up with whatever's going on here, right? So we've got cortical breach, we have got an ill-defined lesion, predominantly radiolucent, and then the next thing you want to do is to see whether there's any soft tissue component to this. And I don't think you can really say that you can say that there's a soft tissue component to this. So you can see a sort of soft tissue density over here. It all looks okay. It doesn't look like there's much else going on, but this is an aggressive lesion, 100% aggressive lesion. It needs to be investigated further. So that's exactly what they did. They decided to do a CT chest, abdomen, and pelvis because we are concerned that someone this age have got a destructive bone lesion located within the radius like that. They may have an underlying malignancy. So let's do a scroll through all the way down, all the way down, all the way down, all the way down. And the reason why this is actually quite concerning as well is because so much of it is gone that they could end up having a pathological fracture. Keep going, keep going, keep going, keep going, keep going, keep going, keep going. Okay, good. So what have we seen? Small hiatal hernia. Looks like that's some previous gastric surgery. Coming up to the top, and this doesn't look right. So let's we go to the lung windows. Where are the lung windows? There. Scroll down, and it looks like there's actual like a collapse of the right upper lobe. Because now you've got you all you've got is an oblique fissure, middle lobe and lower lobe, but the right upper lobe seems to be predominantly collapsed. Okay, so that's not good. You can see the bronchioles sitting within there, like these linear things going all the way down, all the way down. So it's completely plugged up. And what may be causing some of it is this sort of lymph node area. And there may be an endobronchial lesion as well, but there's these sort of necrotic lymph nodes sitting within the mediastinum. One was sitting just there. You can draw that there. And there's another one that could be potentially sitting over here as well. So this looks like necrotic lymph nodes, right upper lobe collapse and consolidation. Then we've got to see whether there's any other lesions anywhere else in the lungs, which I don't think we can see. Because we've got CT abdomen and pelvis, we've just got to have a look and make sure that the adrenals are good, which they are. Kidneys look good. The liver looks good, so I haven't seen anything metastatic so far. And then the bowel, let's follow up, follow up. I mean, I don't think, I mean, we've seen a primary, but I just do this by habit. And I guess over years of doing it, I can get pretty quick at going across transverse colon, transverse colon, transverse colon. We are at the hepatic flexure. And yeah, bowel looks okay. Looking for lymph nodes. So these are lymph nodes, tiny ones. These ones that kind of come in and disappear, come in and disappear. They're not enlarged by CT criteria because they need to be more than 1 centimeter. But you can see, look, vessel, vessel, and then that thing. It just sort of comes and goes. So that must be a lymph node. Another lymph node there comes and goes, comes and goes. So these are all small lymph nodes so far. We have some mediastinal lymph nodes, any axillary lymph nodes, some, but they're not particularly worrying either. And now we did have a destructive bone lesion in the right forearm. So we have to be concerned they could have a destructive bone lesion somewhere else as well. So let's scroll through. Let's scroll through, scroll through, scroll through. And I don't think I've seen anything destructive just yet anywhere else. It's quite an interesting scan. It starts off with the forearm. They come in with bright forearm pain and they end up having what looks to me like an underlying malignancy located within the lung, causing right upper lobe collapse. Good. Let's have a look at this one and let's just download this. Pretty quick, isn't it? I mean, that's rapid. How quick. I think that might actually download faster than some of the teleradiology work I do sometimes. Sometimes. Okay, let's scroll through, scroll through, scroll through. So we have got reduced urine output, and we also have abdominal pain and loss of weight. So, right, so they look like they've had previous surgery. You can see there's a big stoma and there's a whole lot of intra-abdominal fat that's herniated through. So it's a parastomal hernia, but the bowel actually looks okay. Doesn't look like there's anything going on. But when you come to the kidneys, do you remember when I was talking about parapelvic cysts versus actual hydronephrosis? So this time you can see a little bit of fat, but most of it's gone. On this side, almost completely gone. There is literally no perirenal or intrarenal fat there whatsoever. And instead, you've got really grossly dilated hydroureters, ureters going down. They're going down like snakes all the way down into the pelvis, all the way down. And now we've got to think, okay, what's going on? Do they have like a calculus? Is that a calculus there? See the other side. But then why is it causing such significant obstruction? And actually, I feel as though you can follow this down. So what we'll do, we'll zoom in, go from here, follow me here. Follow, 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 and it kind of veers off this way, coming down. A bit hard to see now. Ooh, coming down, very hard to see. Oh, I can't be convinced I can see it, still see it. Very hard to see. But I wonder whether it kind of gets really thin. So it's around sort of the lower abdomen area that it starts to get kind of quite dilated. So we have to think to ourselves, what could be causing it? We haven't seen any evidence of any calculi. The urinary bladder actually looks okay. So what's actually happening is that the ureters are being pulled inwards, downwards, and you can also see the sort of soft tissue thickening around the area here, around the posterior aspect over here. So there's a fair bit of soft tissue thickening going on here. They've clearly had a previous malignancy of some sort, or for whatever reason, they've had some bowel surgery. There's multiple reasons for someone to have this particular thing happen to them. But this is more, this is going to be bilateral hydronephrosis and hydroureter, secondary to retroperitoneal fibrosis. And this is what retroperitoneal fibrosis looks like. I suspect they did a non-contrast study because their kidney function was really, really bad at the time of trying to do the scan. So have a look. Yeah, so retroperitoneal fibrosis, multiple causes that can be doing it. I think lymphoma is going to be a big one. So let's have a look. If the spleen is not particularly big, lymph nodes wise, I'm always careful of these because sometimes they look like lymph nodes, but when you look on the sagittal views, they connect and then they actually turn out to be like paraspinal veins. So just be a bit careful. But that doesn't look right. That thing there, it kind of comes and goes. This circle anymore? Can't see anymore. Okay, so there is what looks like an enlarged lymph node, retroperitoneal fibrosis. They're probably going to need to have nephrostomy stuck in, especially given they've most likely had a non-contrast scan because of bad renal function. Oh, okay, so cool. We have hit the end. We have hit the end of the talk. Been through a few cases. Hopefully showcased Collective Minds to you guys. I think it's a phenomenal platform. Used it for my own teaching both for FRCR and for my company Radiology Seminars. If you are interested in getting more teaching from myself or my company, please do check out Radiology Seminars. Or if you just want to keep up with me, go to my website, imranlasker.com. I don't do Twitter anymore because of Elon. But yeah, I'm on Instagram and YouTube and all that kind of stuff if you are interested. But I think that's it from me. So are there any questions? And I think Danish wanted to ask a couple of things or he wanted to say a few things before we go. But I think from my side, we don't have more cases. So I'm going to come off. Oh, yeah. So I should probably say, we have done so many of these. I've done 30 of these things, and it's an amazing opportunity that has come my way. I still remember doing the first one, and I was completely way out of my depth, man. I felt so out of place. And as the years have gone on, I mean, I've learned a huge amount from doing it and about presenting and learning. And as you guys have interacted with me, I've obviously made mistakes and learned from those as well. So it's been an amazing learning experience for me, and it's opened lots of doors and met lots of wonderful people. And occasionally I bump into someone who says they've been to my webinar and they've really enjoyed it. And so I think the whole point of all of this, I personally feel, is that it's always I'm hoping that something that I teach will end up helping you help someone else, and then hopefully that'll come back to me on some level. So yeah, it's been about 2.5 years of doing this. So. It might not be over. I might be on another platform. I might be doing more work with you guys. Let's see. It just depends on what the people want. What the people want. Okay, until next time, have a great evening. Bye.
Thank you, Dr. Lasker, and a huge, massive thank you on behalf of Collective Minds as well of showing up each month and giving us so much value in terms of cases. So, this isn't the end. This is just the final one for this series. There will be some more, hopefully something launched later in the near future. But as for now, if there's anything that you want to see in future webinars, please do complete the survey I just set in the chat. There's a section there where you can give some suggestions. And once you do complete that survey, you'll all get a CPD certificate as well. So be sure to fill that in. And this was the seminar that was shared earlier on, that'll be available for a month. So you can go back to the cases and review them again. And the recording of this will be available on the Collective Minds YouTube channel. And that's all from me. So thank you, everyone, and have a great evening.